Go ahead.
So as you can see, this patient is a 70-year-old with this was at T11, I think it was T10 actually. You can see the conus ends here. Spinal cord compression with kyphosis and basically unable to walk with severe leg weakness.
And again, I'm just going to interject because we are going to broadcast it for a big group of people, might be lots of students and so on. The spinal cord in an adult usually ends at the border of L1, L2. That part we call conus medullaris. After that, filium terminalis start, where there is a cord, like as you see here, you see that Dr. Kim, based on his experience, knows that the conus is there, so that might be that what level it is, using his anatomical knowledge to identify the level. But as you can, Dr. Kim can point to the tip of the conus. Can you please, Sunny?
Yeah, right there.
So that is where the tip of the spinal cord is. When we are in the belly of our mother, actually that tip goes all the way to the sacrum. When we grow, the nerve retracts up. By the time we are an adult, in most of adult, the conus or the spinal cord itself ends at L1, L2, meaning damage above it can make you paralyze you on the legs. Damage below it usually doesn't affect all these levels because there are no more cells in that filium terminalis. These are just axons. They are much more resilient. Okay, please go ahead, Sunny. Sorry for the interjection.
No problem. So in this case, you can see there's actually pressure coming from the front of the cord. Okay, so this is the back side here, this is the front side. So you need to actually go around the spinal cord to take out that offending bone fragment, okay? And which is somewhat difficult to do. Traditionally, we had to open up the chest, take the rib out and go through the chest, and which is quite morbid procedure, especially 75-year-old lady. You don't want to go into her lung and take this out, and then you still need to put some screws in the backside for fixation. You cannot just go in the front and take it out and just leave it like that. Okay, so you got to restore. You can see it's a collapse about 30 to 40 degrees. So she's about 30 degrees out of alignment. So you got to correct the deformity as well as take the pressure off the spinal cord. So there's no question. In this situation, patient needs surgery, unless you want to just be like euthanasia. You just ignore and just leave it in a nursing home, and just let her die because she cannot walk.
Yeah, and that sounds like a horrible thing, but in reality, sometimes that happens. We as a surgeon, we always have to balance risk versus benefit. So if the choice you have, if you truly have only this choice, do a big thoracotomy, do a 8-10-hour surgery on a fragile patient, you may kill that patient. In that case, it is reasonable for the surgeon to decide. The risks are not justified. So even though it sounds horrible when Dr. Kim says that way, it is in reality something is happening with the open old-fashioned surgery every day, even in the United States. So please, but you decided you can provide a less traumatic surgery to this patient, Sonny. So go ahead.
I decided basically do a laminectomy, to expose the spinal cord and kind of go around the spinal cord and remove. This is the axial view. Before you can see the severe pressure on the cord. And I decided go in there and take out the whole thing and decompress the spinal cord. And you got a big filling defect once you take it out. So this is a Ulich expandable cage, titanium. I think it's 2.5 millimeter diameter. And so I basically take out the pedicles, go around the spinal cord, and decompress the cord both front and back. And put the cage in there, kind of jack it up. You can see the anatomy is completely restored here. It used to be kyphotic, 30 degrees, now basically the zero where it should be.
Well, first of all, I think it's a 2.5 centimeter, correct? And,
2.5 centimeter.
And I think that the take home is here that, when we surgeons start doing spinal surgery in the lumbar spine, in the lumbar spine, we just talked about that. There is no cord most of the time down below. Your nerves, those nerves are, you can push them out of your way. You can retract them. Once we got a little more confidence, we start doing that in the cervical and thoracic spine. We surgeon truly damage the patient because where there is a cord, it doesn't tolerate retraction. For that reason, about 30 years ago, most of people said, okay, we cannot go from the back because we cannot retract the spinal cord. So we did these huge thoracotomies and so on and so forth. Now the technique is being more refined that we can approach anterior part of the cord mostly from the side by taking enough bone off from the side to slip like this Cajun. But that requires not only laminectomy, but requires taking enough bone out that you can slip the cord without pushing any pressure on it. And in this case, Sonny, did you do a total facetectomy and pediculotomy, or what exactly did you do? Can you go?
So basically this, I want to decompress the spinal cord well, so I have to resect both pedicles.
Okay, so you do a bilateral pediculotomy, okay?
Yeah, pedicles, and once you do that, then you don't want to retract the spinal cord. You can kind of gently protect the dura, maybe a couple of millimeters, but you cannot yank it. So basically, you have to resect the pedicle so you get enough maneuvering room, and
and you just said something that I think is extremely important. I want to, just emphasize that. You just automatically say you did a pediculotomy on both sides, and it's totally understandable for you and I. But to explain that is that, if you do a pediculotomy on one side and you manipulate to put something big on that side, if there is any pressure on the spinal cord, it pushes the spinal cord against the other pedicle on the other side. By you naturally doing pediculotomy on both sides, even if there is a little pressure, it's not pressing the spinal cord.
A little more flexibility.
Yeah, so you're not pushing the spinal cord against the pedicle on the other side. You are not squeezing the spinal cord because we know it doesn't take much to make a damage if you squeeze the spinal cord in that level. But you're saying it as a matter of fact, but these are experiences that you gather over tens of years. And there is a saying for the thoracic spine: if you do 5 of it, you are an expert. If you do 5 of it a year, you are an expert. And you guys know that just Dr. Kim and I, we are one of or two of very few people generally in the United States doing this thoracic case regularly. As a matter of fact, I think Dr. Kim does even more cases than I do. But here, in a thoracic case, this was declared for 8 years. Patient goes from neurosurgeon to neurosurgeon, and they refuse to do surgery because exactly what we discussed. When I saw this patient, you see that there is what looked like a calcified disc here pushing on the spinal cord. And if you look at it carefully, that yellow and the orange part is what's left of the spinal canal. Here, the big circle is what's left of the spinal canal. The spinal cord is literally squeezed to the side, and here's the pathology. And patient is in follow-up every month, every year, losing more function. And we are just watching the patient because many surgeons think by them not having enough experience to do that, by them doing the surgery, actually they are going to damage the patient even more. So I'm not faulting those surgeons, but this is the reality. Now, to do a surgery, again, you see the pathology well. Now, I'm going to just go to this picture here, and here on the CT, you see what I'm talking about, the hard disk. So these are the steps of the surgery as Dr. Kim is describing it. If this is the lamina, we come from the back, the first step is to do the laminectomy. Laminectomy gives us only so much approach. But it opens up, so the spinal cord is now all of a sudden not under much pressure. This is not enough though. Now we have to do the facetectomy. By doing facetectomy, and again, Dr. Kim said that, and this is the right way to do that, you do it both sides, that if you're manipulating on one side, you're not pushing the spinal cord against the other facet. Then you do costotransvertebrectomy, that gives you a little even more approach. And then the next step is pedicle osteotomy, which is doable. It's and then once you do that, you have what we call skeletonized the spinal cord. That gives you enough space to do a full corpectomy or even put an expandable cage in. Gökaslan in Hopkins has popularized that, and he has beautiful videos and so on. He gives presentation, but Gökaslan is on top of his field. Here in this conference, you have two people who do that regularly, Dr. Kim and I. So we are competing with, in this kind of, on the technical side, with places like Hopkins. Now, the reality of it is this. You see here, spinal cord, the nerve root is skeletonized. And this is one of my cases. You see that again, spinal cord skeletonized, the nerve roots. Here we are in the thoracic region. Even if one of the nerve roots is truly in your way, you can safely dissect and resect it. In that level, the intercostal nerves, they just have function for very minimal amount of muscle and skin in the chest area, and it can safely be dissected, but you have to do it the right way. You have to...
Let me interject one thing along this line. One thing is that before you tie the nerve root off, sometimes, Adamkiewicz, some feeder vessels to spinal cord come through the nerve root. Mm-hmm. So people have kind of put a little clip on it temporarily and watch the SSEP. And after about a few minutes of temporarily clipping the nerve root, there's no drop on a signal. You can go safely take it out.
Great point, great point. Adamkiewicz is one of the major vessels that goes directly from aorta and supplies the spinal cord with blood supply. And in some people, after manipulating or dissecting the Adamkiewicz artery, people become paralyzed because that section of the spinal cord doesn't get blood supply. And what Dr. Kim is describing is you're monitoring the patient with the SSCP, EMG, and so on, and literally putting a temporary clip on the nerve root that you want to dissect. If that section of the spinal cord doesn't get blood supply, you see the changes in the SSCP and EMG, or SSCP and motor evoked potential. Then you just take your clip off, no damage, no harm is done. And then, but if you keep it there for 5 minutes, that is usually what my threshold, I keep it for 5 minutes, and if nothing's happening, then you go and you can ligate it and dissect it and has no consequences whatsoever. But here, look at that. Now, I want you to see that in a closer up, that you see the vertebral body underneath the nerve root, and I'm passing a probe underneath the spinal cord. So practically, I'm opening everything up without putting any pressure on the spinal cord. And this is the final result that I have put my screws here. Here, I'm going 2 levels above and below. Bone quality was good enough. And I'm putting a crosslink across that segment. So this is, this is the surgery flow that I'm just putting some surgery flow. The surgery flow turns into scar. So I'm literally producing some controlled scar tissue between the hardware and the spinal cord to sort of encase this spinal cord in some living tissue as well. So, and I'm going to unshare that. And then this is the post-op CT of this case. And this patient did really fantastic. And how did the patient do, Sonny?
The patient did good, no problem at all. Yeah.
Excellent, excellent, excellent. Okay. Well, I think that sort of we should be able to conclude that our meeting here. And that was great. 2 great presentations, Sonny. Thank you.
Okay.